Hello dear students, today we will discuss a very high yield clinical vignette on acute promyelocytic leukemia or APL. This is very important leukemia for exams because it is not only diagnosable from the classical clinical picture but it is a true hematological emergency because you have to start the treatment immediately as you think the patient is having the features of APL. So let's start with the clinical picture. The patient in this vignette is a 35-year-old female who presents in the emergency department with acute history of fatigue, bruising, recurrent nosebleeds. She reports no past medical history and no history of any medications. On physical examination, her temperature is 100 degree Fahrenheit, blood pressure is 110 by 70, heart rate is 112 beats per minute. She appears pale. Examination of her skin reveals diffuse petechiae over her lower extremities and large ecchymosis on her arms. There is active oozing of the blood from her gingiva and there is no hepatosplenomegaly or significant lymphadenopathy. This clinical picture suggests a acute history with fatigue, paleness, fever and bleeding. Fatigue and paleness suggest reduced red blood cell count. Fever suggests reduced WBC count or abnormal WBC. Bleeding suggests reduced platelet count or any coagulopathy. The differential on the basis of this clinical picture can be the acute leukemia or aplastic anemia. Now look at the investigations. Her WBC count is low, hemoglobin is low, and her platelet count is markedly low. Her prothrombin time and APTT is increased, suggestive of coagulopathy. Her fibrinogen level is reduced and D-dimer is markedly elevated. This pattern of coagulation profile is suggestive of an underlying process going on which is known as DIC or disseminated intravascular coagulation. In acute promyelocytic leukemia cases, this is the main hematological emergency which should be treated immediately because in the absence of treatment, patient may go into the bleeding, especially in the CNS bleed, and may die early. So DIC is the main reason for early mortality in cases of acute promyelocytic leukemia patients. Now come to the blood picture. In this peripheral smear, we can see an abnormal promyelocyte with needle-like cytoplasmic inclusions. These inclusions are OR rods. So when multiple OR rods are packed together, they are known as like this. Then the cell is known as Fagot cell. Which are classically associated with acute promyelocytic leukemia. OR rods uh, are derived from the primary granules or azurophilic granules of the myeloid cells. Now come to the MCQs. The needle-like cytoplasmic inclusion seen in the atypical cell on peripheral smear will stain positive for which of the following markers? So the TDT, PAS, MPO, TRAP, LAP. TDT and PAS will be positive in lymphoblast. TRAP is positive in hairy cell leukemia, and LAP will be positive in leukemoid reaction, in which it is high, and in CML it is low. So the choice C, which is the myeloperoxidase, it is the correct answer, and it stains the rods or myeloblasts. Now come to the next question. What is the primary mechanism of immediate life-threatening complication in this patient? So in this patient, the as we have seen, the PT and APTT were abnormal, they were high. Fibrinogen was low, and D dimers were markedly high. So this type of, and platelet count were low. So this type of coagulation abnormality favors a concurrent underlying coagulopathy is going on, in which there is consumption of coagulation factor is going on, and there will be breaking and shedding of the D dimer um, from the fibrinogen. So in this condition, fibrinogen will be consumed and D dimer will be increased because it is the breakdown product of the fibrinogen. So this is the medical emergency which is known as DIC. So what is responsible for this? Answer is the C, release of tissue factor like procoagulant from the primary granules. The primary granules in the promyelocytes release release a tissue factor like protein, which further activates the coagulation cascade and causes the DIC. Other choices, let's see other choices. Release of uric acid and intracellular potassium from the rapid cell turnover. This is the feature of tumor lysis syndrome. Tumor lysis syndrome usually not seen in acute promyelocytic leukemia until unless the TLC WBC count is very high. Accumulation of massive blast causing capillary sludging. This is the feature which is known as leukostasis. Leukostasis can be seen in malignancies like ALL or AML when the counts are very high, like more than 1 to 2 lakh. Autoantibody production against the platelet surface glycoprotein. This is the key pathogenesis of immune-mediated thrombocytopenic purpura and not the APL. Infiltration of meninges by the malignant cells. No, this is more commonly seen in ALL and AML and very less likely to be seen in cases of APL. So now based on the clinical presentation and peripheral smear, what translocation you would like to see in this case? Um, Translocation 814 is seen in Burkitt's lymphoma. Burkitt's lymphoma. 922 is seen in CML or Ph positive ALL. 1114 translocation is seen in mantle cell lymphoma. 1418 is seen in follicular lymphoma. The remaining one is the D, which is the right answer. It is seen in the cases of APL, and this translocation generates a fusion protein which is known as BML-RARA. This protein blocks the maturation of promyelocytes, and this blockage creates the APL. Which targeted pharmacological therapy should be initiated immediately for this patient? Imatinib is used in CML, rituximab is used in B cell NHLs or autoimmune disease. Venetoclax is used in acute myelocytic leukemia. Dasatinib is also used in CML. The remaining choice and the correct answer is ATRA. ATRA is the first line treatment of the acute promyelocytic leukemia, and it should be started immediately even if the suspicion of the APL is considered, even in the absence of molecular diagnosis, because early mortality due to the bleeding is very common in APL cases. ATRA should be started immediately, and other drug which should be started with ATRA is ATU or arsenic trioxide. So this is the first line treatment for the APL. Now come to the next question. A few days after initiating the correct targeted therapy, the patient develops dyspnea, fever, weight gain, and bilateral infiltrates in the lungs. And what is the most appropriate next step? So a few days after starting ATRA, if patient develops fever, dyspnea, weight gain, and bilateral pulmonary infiltrates, then always think of differentiation syndrome. This occurs because differentiating myeloid cells release cytokines. As we have seen, the PML-RARA blocks the differentiation of APL cells, causes the malignancy. This block is inhibited by the ATRA, and ATRA unblocks this and causes the maturation of the cells. And as cells mature, they release and granules out of them, and this release causes the a cytokine storm like phenomenon, which causes the capillary leak, pulmonary infiltrates, pleural effusion, pericardial effusion, weight gain, hypotension, renal dysfunction, and respiratory distress. So it is a life-threatening complication of starting the ATRA or arsenic trioxide in cases of the acute promyelocytic leukemia. So what is the appropriate next step therapy for this case is the high dose dexamethasone. The dexamethasone suppresses this cytokine release and reduces the inflammatory responses, and thus helps in the management of this differentiation syndrome. Broad spectrum antibiotics should be continued because it is sometimes very hard to differentiate between the differentiation syndrome and this sepsis. Other options like stopping this targeted therapy permanently, it is not good. So the correct answer is the high dose dexamethasone. Furosemide can also be used, and therapeutic leukapheresis is not the correct answer because it is used in cases where there is the TLC count is very high to treat the leukostasis or to prevent the leukostasis. So for the differentiation syndrome, dexamethasone is the drug of choice. So the take-home message is simple. APL presents with the bleeding and DIC. The smear shows abnormal promyelocyte with OR rods. OR rods are MPO positive, and genetic lesion is translocation 1517, producing the PML-RARA. And the treatment must begin urgently with ATRA-based therapy. The two lethal complications of APL are the DIC, which is the early complication, and the differentiation syndrome, which can be treated with the use of dexamethasone. So in exams and in real life, missing the APL can be fatal, but recognizing it early can save the patient. So that is all for today. Thank you.